to sign up today.
Prostate cancer is the second most common cancer for men, and colorectal cancer is the second leading cancer killer in the country. Here now to talk about advancements in treatment and prevention of prostate cancer is Dr. Roscoe Nelson of the Arizona Center for Urology, and to speak about colorectal cancer is Dr. Neeraj Singh of the Valley Surgical Clinics. Good to have you both here. Thanks for joining us.
Thank you.
Start with prostate cancer. Second most common behind skin cancer. This is it, huh?
It is, and it's the #2 cancer killer of men in America. That's a number that people don't realize because it's such a common cancer, and most people hear, if you live long enough, you're going to get prostate cancer. It's a lethal cancer. It's the #2 cancer killer of men in America.
Is it a more lethal cancer the younger you are?
The surprising statistic, people think of people that are very old that are dying of prostate cancer. Average age of dying of prostate cancer is 64, much younger than what most people think.
How long have those, on average, how long would that particular patient have had prostate cancer?
Really depends on how aggressive that cancer is. Prostate cancer is a mix of some very slow-growing cancers, but then there's a handful that are very aggressive, very fast-growing. So these ones that kill people tend to be around for maybe less than 5 years by the time they get out, go to the bone, go to the lymph nodes, and get to the point where we can't cure them.
Colorectal cancer. Give us a definite. What is colorectal cancer?
So basically it's a cancer which arises from the cells within the colon lining or the rectal lining. So we call it as a lower intestinal tract. So we have like a small intestine and large intestine, so it's mostly from the large intestine.
Are there symptoms of colorectal cancer?
Yes, mostly patient comes with the bleeding. They can have obstruction if they're very advanced. Sometimes people present with the anemia, and that's another symptom. Those are the common symptoms that we look for. Abdominal pain is the advanced symptom when people have obstruction, and they come with the complete blockage or obstruction symptoms.
Risk factors. What do we know about colorectal cancer and risk factors?
Most of the colorectal cancers, to the contrary, people say it's genetics, but most of the common cause is sporadic cancers. So 96-95% cancer, they are sporadic. Risk factors, diet, environment, your lifestyle, I'll say, we are mostly sedentary lifestyle, obesity, smoking, diet, mostly red meat is most common cause that's been categorized as the risk factor.
As far as symptoms and treatment for prostate cancer, I mean, are there symptoms of prostate cancer?
Once it's spread, there are symptoms. You can have blood in the urine, pain in the bones. When I trained back in the 90s, that's how people presented. They came in with bone pain, and that's how it was diagnosed. Now with PSAs, we're able to catch it early, but there aren't a lot of symptoms of early prostate cancer that hasn't spread yet.
You brought up PSAs. What is a PSA test, and why is this particular test controversial?
Well, PSA, it is very controversial. It's just an enzyme. Every man with a prostate has a PSA level in their blood, and it's normal. It helps actually it's an enzyme that helps get a woman pregnant. But PSA, we started testing for it in the late 80s, early 90s, and what happened is we pulled out a lot of people that already were metastatic that hadn't been treated yet. And so when they looked at it after about 5 years, they weren't seeing an improvement in the death rate of prostate cancer. So they started to question, are we doing the right thing? And if you look at the long-term data, the Swedish data, the European data, we are actually seeing a big success with that. If you look at any short-term study, you're not seeing that success. So we just have to be better with it. And the controversy is we need to also be more selective in those who we treat with prostate cancer.
Who would be someone that would not necessarily need a PSA test?
If your life expectancy is less than 10 years, it's probably, you don't need to check for your PSA. And I think that's probably the #1 is the older you get, the less likely you're going to die of an aggressive disease. If somebody comes in, and I always laugh, a poor old guy comes in a wheelchair and oxygen and they have a PSA, I do everything I can to say it's okay. It's as long as it's reasonable.
It could be around longer than they are, in other words.
Most of the time it is.
As far as colorectal cancer, I mean, third most common cancer, second leading cancer killer. Boy, that second leading. What makes colorectal cancer so deadly?
I'll say it's the diagnosis. Most, like in America, we are pretty advanced as far as screening is concerned. I'll say the colonoscopy has been one of the best, like I'll say, in the history of mankind, as the best screening test ever, been detected. But if you see over the world, People, they don't have any screening protocols. Other thing which is in America, we are seeing more and more is the younger age. Medicare approves the screening starting from the age of 50. But in the data, if you see the literature, last 15, 20 years, most of the patients, they are between 40 and 50, they have been getting the majority of the cancers, and I see it all the time. Because the screening has prevented, we detect the cancers early with the polyps. It's a polyps to how the cancers form.
When you find polyps, what happens? What's next after finding a polyp?
Next step is if they can be removed endoscopically with the screening, colonoscopy, that's the best, because you just stop the progress of the disease. And then based on the number of the polyps, the size of the polyps, then they need further follow-up colonoscopies. But in the younger age, like 40 to 50, because there's no screening yet, and we are seeing, because of the environment and the diet factors, we are seeing more and more younger people with the cancer.
And as far as these precancerous polyps, do you know immediately it's precancerous? Does it have to go be tested after you remove it? How does that work?
It depends a lot. There are morphological features. Most of the people who do colonoscopies like routinely, like I do, we know like what kind of polyps majority of the times. But there are many kind of polyps. Some are flat, some are raised. But absolute answer is with the pathology. Once we send the pathology, and then the pathologist tells it's a precancerous or a cancerous or a non-cancerous polyp.
I asked Dr. Singh regarding risk factors for colorectal cancer. Are there risk factors for prostate cancer?
It's very similar to what he was talking about with colorectal cancers. A lot of it's family history, but diet. Our American diet is not good for us. The processed foods, these types of things, the high-fat diet, it's worse in obesity. There are some other groups, the African American men, much higher risk of getting prostate cancer and getting a more aggressive form of it also.
Is that genetic based then?
Genetic based. We don't fully understand it, but there definitely needs to be that needs to be taken into consideration as we screen these men and do it at a little earlier age and get baselines and then follow them along to make sure we can pick it up early.
And you'd mentioned bone cancer. Is that where most commonly a prostate cancer, if it were to metastasize, is that where it goes?
The bones and lymph nodes, yes.
And so once you find it there, different ball game, correct?
Different ball game, different treatment. You have to begin systemic treatment. You have to take the whole body into consideration, treat everything.
Talk about those treatments. What are available out there?
So for years, in fact, the Nobel Prize winning research on testosterone and the relationship with prostate cancer is to remove the testosterone, and that's the first method of, and we do it with shots now, first method of treating metastatic prostate cancer. There's some good research recently that combining that with chemotherapy actually improves the longevity. When I came out, even in the 80s and early 90s, when people were diagnosed and it was in their bones and they failed hormones, the life expectancy was less than a year. Today it's much longer than that. In the last 3 years, we've had 4 new medications, 2 of them oral, that will improve not only the hormonal treatment but the chemotherapy.
As far as the PSA test is concerned, let's say it's high-ish, okay, and let's say that there are other indications, other testing says, something's going on here. You find out there is cancer there. Can someone beat prostate cancer completely?
Vast majority of men are cured of prostate cancer. The question is, there are a lot of men who don't need to treat it. If I was 75 and I had a very small volume of a low-grade cancer, that's a guy that a watchful waiting protocol would be the way to go. Be very aggressive in checking PSAs. Do a biopsy 6 months later. Follow that person. See if only about 10% of those people progress to a more aggressive form, and you can still catch it early.
But again, if you are younger, the odds are a more aggressive form of treatment is required.
And we still cure the vast majority of that group of men with that disease.
Treatment for colorectal cancer, what's out there? How effective is it?
I'll say it's a very, very effective treatment. Currently, overall, it's about 61% survival, 5-year survival rate for the colorectal cancer. Surgery is the primary treatment for early stages, stage 1 and 2. Stage 3 depends, treatment for the colon and the rectal cancer differs. In the rectal cancers, we use radiation as a neoadjuvant modality. And in colon cancer, obviously, we never use the radiation. So it's a little bit different.
Have those treatments evolved, though? I mean, are things different now than they were 5, 10, 20 years ago?
Absolutely. There's a lot of new studies going on. And with the quality of the surgery improvement, we're using more and more minimally advanced robotic techniques. So patients are recovering fast. They go home fast. essentially we are shortening their time in the hospital. So that's one of the major advantages.
You know, we had mentioned that the third most common cancer, second leading cancer killer, colorectal cancer, and the idea that it's something that can be, if not cured, certainly found early, treated better. Why don't more men get screened?
Well, there's a lot of factors. It depends. Patients are just scared of colonoscopies. And many patients are, like I still see patients in my office, they say, oh, we're worried about perforation, we are worried about, I think that's a major dilemma in the patients. Many patients, they don't want to go through that discomfort, the discomfort of the bowel prep. Patients don't want to go through that. But I think it's a very simple test in the common word, and everybody in America, it does it.
Those concerns regarding perforations and these sorts of things, success rate on that improving over the years? Do we see that as much as we used to? Did we even see it all that much in the past?
It's very, very rare, and it depends upon the volume, and we see it very rarely, those kind of complications.
As far as prostate cancer is concerned, on the horizon, what are you seeing? Are there new treatment techniques, new diagnostic techniques out there? What's happening?
Well, from a treatment standpoint, we're better at surgery, we're better at radiation, they're better at chemo, they're better at immunotherapy. There's all these different ways of treating it. But in patient selection, I think that's where the big change is coming. We're seeing you take two people with the same cancer, the way we used to grade it, and now we're able to get into the DNA and look at it and stratify those into guys who are high risk of progressing and people who are low risk. And maybe we're going to be less aggressive with this one and more aggressive with this one. Go early on after that cancer, be more aggressive with it.
How do you know what's more aggressive and what's not? Are the PSA numbers a certain range, or how does that work?
You can have a guy come in with a PSA of 8 and a Gleason 7, and their genetics can be totally different. There are certain genes that control whether the cancer wants to spread, whether the cancer wants to grow fast, and we can look at those and help determine and help that patient make a decision on what to do with their cancer. I think the key, you asked him about screening. Men are a little bit scared of the whole rectal exam, and that's part of the screening. You need it's not just the PSA, there's a rectal exam. About 15% of prostate cancers are found with nodules, normal PSAs, and sometimes those are the more aggressive cancers.
Wow. All right. Real quickly, you optimistic now on treatment for colorectal cancer?
Absolutely. Your patient recover, we detect them early, it's 100% curable.
All right, very good. Hey, it's good to have you both here. Thank you so much for joining us.
Thanks for having us.
Good information. Tuesday on Arizona Horizon, we'll hear from an opponent of Proposition 123, the school funding ballot measure, and we'll look at a new study to be released tomorrow on marijuana use and driving. It's at 5:30 and 10 on the next Arizona Horizon. That is it for now. I'm Ted Simons. Thank you so much for joining us. You have a great evening.
Arizona Horizon is made possible by contributions from the Friends of Arizona PBS, members of your PBS station. Thank you.